Infectious Disease, AMRI Hospital, Kolkata.
No, not this one.
Which one is Newer Diagnostic and Sepsis? I think this one.
Thank you, Dr. Mukherjee, for the wonderful presentation. So I will be taking forward the session with the topic Newer Diagnostics in the Management of Sepsis. So in 1670, you can see the microscope over here. So that was the latest innovation that we have in the 16th century. Moving forward to that, the guy in the other picture, he is in the International Space Station doing a particular diagnostic test just with his tab and a small kind of chip. So I'll be discussing the other part in the later part of the presentation. So sepsis is all about the host response and the infection. So where is the infection in the body? So it's very important. You are dealing with sepsis, that means you have to diagnose the source of the sepsis as well. So in the diagnostic techniques, you have got microscopy, culture, antigen assays, serology, molecular and imaging. So you have to use a particular one for your patient that you are going to decide. And so many things are there in the armamentarium, maybe not all in your hospital maybe, but surely maybe in 10 years, 20 years, you will be getting some of those in your hospital as for sure. So what about the cultures? Obviously culture is a gold standard. You don't have to think anything about it. If you get culture positive, most probably you are having infection with that particular bacteria or fungus. Now the problem with culture is that culture will take some time, minimum of 48 hours up to 72 hours or even more. So sepsis, everything has been bundled in 1 hour. So you need to have certain diagnostic technique that will give you a rapid diagnosis of your particular infection. So cultures will give you the antibiotic susceptibility. Okay, so it has got many limitations. It will grow contaminants. Prior antibiotic treatment will hamper in your diagnosis of the bacterial infection. Many organisms do not grow in cultures. There is no uniform culture media. Now we do have the culture bottles and all, but previously there was an issue. Lower sensitivity, fungal cultures take a lot of time. So there are many problems with the cultures. That's why we are moving forward to the rapid diagnostics. Culture will be there. You have to send your blood cultures or any other culture before starting the antibiotic in the first hour when the patient presents to you. But you have some other armamentariums which you are going to use so that you can get the diagnosis early. So first of them is the automated microscopy. So microscopy is there. Everyone knows that. You must have all used your microscope in your at least second Prof MBBS. But this is something new. This is all about artificial intelligence. So if you have a point of care test lab, and you know how to make a smear, you just make a smear, maybe do a stain and put it inside the automated microscopy. That microscope will tell you whether you are dealing with some gram positive, gram negative, or there is a pus cell in the urine or whatever. If you are not like sure what is it, you can put it over there and it can be done. It's all obviously in research only, it is not available yet, but maybe 20 years down the line you may have this kind of microscope in your lab. So there are multiple papers, multiple studies have been done, and it has shown a good result of it. Now moving on to the immunochromatography. This is something very simple, a small card test. You all know there is a card and you just put the plasma or urine or something. Then it will give 2 lines, one test, one control, and within say 15-20 minutes you are getting some kind of a report. So application is there obviously for malaria. You are writing a malaria dual antigen, and if you do it yourself you will get the result within 30 minutes and then you start the treatment. So this is also done for other parasites as well. Now there are multiple card tests that are available for like Mycoplasma pneumoniae, H. pylori, even Vibrio cholerae. Okay, and there is a one card test that is coming up for Mycobacterium tuberculosis. And same card test can be done for the viral infections as well. So maybe these are not associated with sepsis. I'm just telling because this is important because these are part of the rapid diagnostics. You can do it yourself in your ICU. So something called lipoarabinum for tuberculosis. So this also can be used in the diagnosis of tuberculosis in your ICU. So again, there is another capillary TB assay, rapid diagnostic for diagnosis of tuberculosis. Scrub typhus, you are getting a lot of cases right now, maybe patients coming to you with fever, with rash, with joint pain, and this particular test, very simple to do, and you can do it in your ICU as well. Mostly your microbiology lab is using this particular test, and you have to send the sample after 5 to 7 days because you are checking for IgM. Now moving on to the non-culture based rapid diagnostic test. So mostly we are depending on cultures, but you do have a lot of other modalities available like MALDI-TOF, multiplex PCR, microarray antigen detection and all. So few of them you must be using in your hospital like the multiplex PCR, the BioFire. Okay, I'll be discussing that in bit of detail. So first about MALDI-TOF, it is not it is something that is available right now. It's not in the research labs only. Few of the higher centers are using this, and it has got a very important, very high sensitivity rate. It actually is has the principle of using the mass to charge ratio. So a laser is thrown onto that cartridge plate. It is very simple to do it. Even I have done it myself. It's very simple actually. So you just put it inside the MALDI machine and it will give you the result within 2 to 3 hours. So you can diagnose fungus, you can diagnose Candida auris, the first modality of this diagnostic innovation where you can diagnose Candida auris was MALDI-TOF. Now you can do it in your Vitek as well. So fungus, any virus, even mycobacteria, those can be detected by MALDI-TOF. So advantages include that it has got a very short turnaround time, sample preparation is very easy, anyone can do it, it is cost effective, the cost of the machine is high but overall running cost is very low, and it has got a broad applicability. Now certain limitations like the identification of new isolate is possible only if they have an updated database. If the database is not updated, then obviously it will not be able to do it. And direct testing from clinical specimen was previously not possible, but now they are coming up to do it from the clinical specimen as well, because if it is done after culture, then definitely it is taking some time. But now everyone is worried that since the patient is having sepsis, I want to do directly from the clinical sample, whether it is blood or say urine or your respiratory sample. Okay, so you can even detect the antimicrobial resistance gene, not exactly gene but antimicrobial resistance, whether that particular enzymatic activity is present in the bacteria. So that is one important thing. So you can detect detection of beta-lactamase is possible, and that is usually done by the ertapenem hydrolysis assay. So whether that clinical isolate is sensitive to carbapenem or not, you can get it done from the MALDI-TOF. So they are trying to bring this concept directly from the sample. Now moving on to the nucleic acid based test, that is called the NATs. So there are certain application methods. So one is the polymerase chain reaction, that is the targeted, you have a particular primer for that particular organism, and there are some others non-PCR based isothermal targets, so there are many numbers of that. So regarding the conventional PCR, you are ordering PCR many of the times, mainly the multiplex PCR, BioFire, you're writing the lower respiratory BioFire, upper respiratory BioFire, CSF BioFire and all. So this is the conventional PCR, it is very efficient, very sensitive and specific, and it has got broad usage. Now limitations include that there is chance of cross contamination, cross reactions, and sensitivity to contaminants and inhibitors. Now about this, this is the same thing, microarray. You can do multiple PCRs together. And this is PNF fish. Again, this is only in the research labs. It is not very commonly used. It is mostly used for detection of Staph aureus and the MAKE gene. So detection of MRSA is possible through this, only in the research labs. This is the important one, multiplex PCR. So we'll be discussing this in detail. So this is a simple machine. It's there in your lab, and you have been using this for quite some time. So a patient with sepsis, so wherever it comes to you, you have to look for the source and you have to treat the patient accordingly. You have to use your antibiotics very judiciously, because if you are using certain antibiotic that doesn't reach that particular source, so that overall treatment becomes useless. So you have to use a syndromic approach, whether the patient has got respiratory infection or a bloodstream infection, GI infection, meningitis or pneumonia. So they have got certain panels for that. So going to a case, he's a 40-year-old gentleman presented with high-grade fever, sore throat, cough and body ache. He had a recent history of travel to Mumbai for some work, and one of his family members also had a similar complaint. So he ordered for a nasal and throat swab for a upper respiratory BioFire. So here you can see that the patient has got a SARS-CoV-2 positive along with a influenza H1 positive. So both are kind of a treatable condition. So this is a dual infection of influenza and COVID. You start the patient on remdesivir, and again you can also give oseltamivir together. So this is how this particular panel is going to help you. So the respiratory panel has got so many viruses like adenovirus, coronavirus, influenza and all, and certain bacteria like Bordetella pertussis and parapertussis, Chlamydium, Mycoplasma pneumoniae. So this is the upper respiratory panel. Got a sensitivity of around 97%, specificity of 99%. Moving on to another case, a 45-year-old asthmatic lady presented with fever, cough, faulty sensorium. Her COVID-19 CB-NAT was positive. She got intubated for airway protection, had type 1 respiratory failure. Chest X-ray showed a left lower lobe consolidation. Now a lower respiratory biofire was sent. You can always send a culture obviously, but that will take some time. So you send a biofire and you get a Streptococcus pneumoniae. Streptococcus pneumoniae is a very difficult to grow organism. Usually you will not find a culture report with a Streptococcus pneumoniae. So this biofire is really helping us. And initially she was started with piptaz and doxy. After seeing the biofire report, you can change to ceftaroline or ceftriaxone or whichever you want. Patient got well, extubated on day 3 and she was discharged thereafter. So this is actually helping us in antibiotic stewardship as well. So initially we started with a broad spectrum, we narrowed it down to a lower spectrum and patient got well and discharged. So this is the pneumonia panel. Here you have got multiple viruses and various other bacteria. You can also have a look at the MEC-A gene or the KPC, NDM or oxalike gene. You can also get the CTXM. So various genes, antimicrobial resistant genes are there. You can have a look at that. You can get the identification of the organism as well. The sensitivity and specificity are good enough, around 96 to 98%. Another case, she is a 45-year-old lady and she is a manager at a reputed bank. Presented with severe diarrhea, fever, altered sensorium for 2 days after attending an office party. Not responding to regular antibiotics, and there is a history of 4 more colleagues being ill with similar symptom. So she got some kind of a acute gastroenteritis and her colleagues got it as well. So this is the GI panel of the biofire. You can see the patient has got a Vibrio cholerae. Okay, so this is a real life case because we are not suspecting from a reputed bank manager to get a Vibrio cholerae from an office party, right? So this was a very difficult case for us, but this GI panel made it simple. So we treated her with doxycycline. We gave her all the support, ventilatory support and well, and she responded really well and she was discharged. So this is the GI panel. So many bacteria like Clostridium difficile, Salmonella, Campylobacter, so many are there. All the E. coli, the viruses and parasites, all of them are there. So sensitivity is of around 98 and specificity of 92%. Another case, 66-year-old gentleman, hypertensive diabetic, had a high-grade fever, headache, altered sensorium. On examination had tachycardia, negligidity, cardiac signs. CSF was suggestive of a pyogenic meningitis, obviously no growth in the CSF. Started on ceftriaxone, vancomycin, and we sent for biofire. So here we got a listeria. So if you get a case of listeria, obviously the patient is an elderly patient. You can always think of listeria in that case, but sometimes you may miss. So patient, we got listeria monocytogenes in the CSF biofire, and we started the patient on ampicillin. Patient responded well and got discharged. So these are certain organisms which will not get in the cultures, and if you don't think that these are certain, these can infect your patient, then you obviously you will not treat for that. So these cases are going to help you. So this is the meningitis panel, again many viruses and bacteria, and also the Cryptococcus neoformans, the yeast. Got a good sensitivity and specificity. This is the blood culture panel. This is a very important one. They call it BCID panel. They have got 43 targets. You can always take the cultures before starting the antibiotics in the patients of sepsis. And whenever the blood culture flags positive, you send it for a BCID panel and you get the result within 2 to 3 hours. Got a very high sensitivity and specificity. Now this is another technology, Verigene nanogrid technology, usually not available that much, but it has got so many organisms, and you can also check for the resistance markers. So there is a certain difference between the Verigene and the film array. It is based on the nucleic acid extraction and hybridization technique, and it has got a separate assay for gram positive and gram negative. So you have to put 2 different assays for this, and for in the film array, the multiplex PCR, you have got the combination of the gram positive gram negative together. You can get the antibiotic resistance genes in the same assay. Now, as something about the isothermal nats, not available in the commercial market. Mostly it is done as per research facilities. Certain difference about that, that it is a single temperature, and some technical details are there. These are not necessary. Main thing is that it is difficult to multiplex. You are just using this test for one particular organism only, like it is used for tuberculosis. And in conventional PCR, multiplexing is possible. You can just give the sample and you can get around 20 to 30 test organisms checked for it. Mostly, as I said, tuberculosis, bordetella pertussis or C. diff. So you have got better diagnostic modalities than this. Now CBNAT. So we are using this platform mainly for diagnosis of tuberculosis and rifampicin resistance. So this platform came in the 2009 and FDA gave the approval in 2013. Now there is a smaller thing called Expert Omni. So again, this is for TB only, not exactly sepsis. This can be used in the peripheral the health centers as well. So this platform is also used for diagnosis of MRSA. So MRSA is not or the Staph aureus is not a big problem in our scenario in our country, but in Western countries, Staph aureus is the main organism causing sepsis. So they are using the Expert platform, and the turnaround time is around 2 hours. So within 2 hours, you can get a diagnosis of this Staph aureus. Now this is the one that we are using, the Expert Carba R. So when you have a sample, you are getting a culture, and if you get a culture report with certain abnormalities, like a patient is having a carbapenem resistant organism, but the cephalosporin is sensitive. Now you have to think what's going on. So if you want to know what all resistance genes are there, and you want to plan your antibiotics accordingly. So in that case, we just need to put that culture sample into the Expert Carba, and you will get these antibiotic resistant genes. The turnaround time is around less than 1 hour, and it is also a cheaper test from the multiplex PCR if you compare with it. So this is how you get the report, like NDM detected, and you will plan your treatment accordingly. So there is a Gene Expert application for bacterial infections as well. So in the Expert platform that you have in your lab, you can do so many tests in that. This is an innovation from India, TrueNat. It is almost like Gene Expert, but the machine is quite small, and you can place it in your lab and you can do it. Now the T2 Candida assay or the T2 bacteria assay. So this is important because this is the only FDA approved test that you can directly do from the blood sample, even without the culture. So the turnaround time is around 3 to 5 hours. It uses the magnetic resonance technology to detect the yeast DNA. So in this one, you can directly take the blood and put it in the T2MR, and you can get the diagnosis. Again, T2 bacteria panel is there. You can use 6 different bacterial species, mainly the escape group of organisms. The clinical data is still coming up, but definitely this one is going to be the game changer because you are doing it directly from the blood, even without the culture. Now, what about the use of nuclear medicine? You are not able to identify where is the source. Sometimes when you know the source, you are using the syndromic approach, but sometimes you may not know where the source is. So in that case, you can use this like ciprofloxacin tagged antibiotics, this radio labeled antibiotics, and you can also use radio labeled cephalosporin or ethambutol. So you are using PET scan, right? When you know we are not able to diagnose the source of infection, you are using a PET scan. So that is also a radioable thing, and you can always use this to find your source of infection. So another case, a boy with acute encephalitic syndrome. So a 16-year-old boy presented with high-grade fever and rigors, followed by a thoracic back pain, diarrhea and limb weakness, followed by neck stiffness, flaccid paralysis of all 4 limbs and absent reflexes. Initial CSF results showed 93 cells, lymphocyte predominance, elevated protein, but a normal glucose and lactate. Developed a fluctuating heart rate, blood pressure, intermittent erythematous skin rash, indicating a severe autonomic dysfunction, Consciousness level dropped. On fourth day of admission, he had focal convulsion of left arm and face, finally intubated and mechanically ventilated. So you don't know what's going on. So there must be some kind of a encephalitis or some CNS infection going on. So CSF lumbar puncture was done, CSF was sent for bacteria, fungus and all everything, whatever you can do. You went did a JE specific IgM, you also sent for HSV PCR, you did a CSF biofire, all came negative. You are still thinking what's going on. So you did the urine and plasma and the rectal swab and everything, you did a RT-PCR of that, dengue NS1, so all everything was coming negative. You also even thought of Zika, you sent it for Zika testing, it came negative. You did a MRI brain, it was done obviously before, I'm showing it now. So lesion in the putamen with a high signal on the FLAIR image. So what you can plan is now the next generation sequencing. This is the next thing that is coming up. It is already there in certain centers. Dr. Mukherjee is doing Sanger sequencing in his lab in Tata Medical Center, but this is the next one. Probably they will be upgrading that, and we also were discussing in AMRI hospital with a certain vendor for doing the whole genome sequencing. So what is the importance of whole genome sequencing or the next generation sequencing? So this is a hypothesis free, culture independent pathogen detection directly from the clinical specimens. So that is the main thing. You have to detect the organisms from the clinical specimen. You don't have much of time. You are getting 1 hour from the sepsis surviving guidelines. You have to start everything and do everything in that. Okay. So universal pathogen detection, very important. And if you are dealing with some novel organisms, the COVID-19, the SARS-CoV was a novel organism. It was detected by whole genome sequencing only. If you don't have that, you will never be able to identify what virus is coming up next. And it has a potential to replace many targeted pathogen tests with a single next generation assay. So on your left side of the screen, you have got the traditional workflow. In the NGS workflow, you have got a clinical sample, clinical specimen. You have got a clinical specimen, you just put it inside the NGS thing, and you got a nucleic acid extracted. You have got a library of the whole genetic material. Sequencing is done and the data analysis is done as per the database, and you can get the result. Now there are certain techniques like Sanger, this is an older one, and we have got the next generation of the whole genome sequencing. So multiple studies have been done already on that, so you can do it on the CSF or your pleural effusions or in your any sepsis patients. So going back to our case of that boy, so a deep sequencing analysis of CSF, plasma, urine, rectal swab was done, and the analysis of the obtained clinical sequence was done through the metagenic pipeline, and there was a presence of Japanese encephalitis virus RNA in the urine sample. So, and no other viral pathogens were detected. So JAV in the original urine subsequently confirmed by 2 independent JAV RT-PCR assays, and finally after day 15 of hospitalization, CSF and serum sample came to be JE-IgM positive. Anyway, we could not do much for the patient, but at least we have the diagnosis. So you may have some patient where you can do something, and this next generation sequencing is going to help you. So now the problem is that you can have a host nucleic acid amplification, because obviously in the clinical sample you will get the host nucleic acid as well. So is that a burden or advantage? That has to be decided. Discrimination between colonization and infection, that is the $1 million question every time when you are using a PCR based test or whenever you are dealing with a DNA of from the sample. So even if there is a colonization, you will get the test report positive. So you have to be clinically you have to assess the patient, and you have to think whether you need to treat the patient with that particular test report or not. Turnaround time is it is higher while you are using with the Sanger sequencing, but when you are using whole genome or the next generation and the ones that are coming up, the turnaround time is really coming down. You can do it within say 4 to 5 hours. So it can be considered as a last resort, but maybe 10 years or 20 years down the line it will come as the first resort, because that thing will be available in the every lab. It can become available in your point of care test lab beside your ICU as well. So it will be very simple to do. Now, just a small thing about that. What is DNA sequencing? Is the process of determining the order of nucleotides. So what is the sequence of the nucleotides? Individual genes, larger genetic regions, or the full chromosome or the entire genome. So the basic sequencing is like the Sanger. There is an advanced thing called shotgun, and the next generation, that is the pyro sequencing or the iron torrent and all. So these are the newer ones. So these are the machines. These are really the small machines. These are not big ones like the Maldi or something. So you can even carry it in your pocket, the mini iron. So next generation sequence is actually a blanket term that collectively refers to the high throughput DNA sequencing that can produce large amount of genomic data in a very short time. It's also called deep sequencing or high throughput sequencing or massively parallel sequencing, whichever one you want to call. So obviously the advantage is that massive parallel sequencing can be done, reducing the turnaround time, and the whole human genome can be sequenced within a day. So human genome project, that project that concluded a few decades back, took a huge lot of time, but right now you can do it within a day. So again, there is a library preparation, there is amplification of the genes, there is a sequencing, and you can analyze the data. Now, what about the application in infectious diseases? It's a clinical metagenomics, discovery of novel pathogen in therapeutics and also in the public health. So, regarding the metagenomics, it is the study of the genetic material recovered directly from the environment samples. For in our case, it is the directly from the patient. So its application include again the culture independent identification, detection of antibiotic resistance. You will get the genes as well, and also the subtyping of the microorganism and pathogen gene carriage detection. So again, you can do a targeted one. Just you have to give the primers targeting particular organisms, or you can do a whole genome sequencing, or just whatever DNA or RNA is there, that will be detected. So you can do it on a respiratory sample, you can do on the CSF, you can do on blood, GI, urinary tract, any sample you put it. Patient is having a septic arthritis, you put a synovial fluid sample, you can obviously get it over there. So our main problem is with the bloodstream infection because the culture rates are really low. So, and that if the culture rate is low, you are not giving the proper antibiotic, and there is a delay in the clinical management. So many studies are going on. So this study actually was done on patients having septic shock. So they did it on the blood cultures, and they have shown that if the blood culture is positive in the 33% of the cases, the NGS will give you a organism in a 72% cases. So overall sensitivity is really going on the higher side. Again, many studies are done on bacteremia in sepsis. The next genes trial. So all the studies are showing that definitely there is an increased sensitivity of detection of organisms. Again, you can do this in the respiratory sample. Many studies are there. You can do it on the CNS infection samples because culture positivity in CSF is hardly 15 to 30%. So this is going to help you. And this particular case had a neuroleptospirosis. So that was detected from next generation sequencing from the CSF. So obviously this will not be possible through cultures. Okay, so again using it for meningitis and encephalitis. So it is easier to use it. So these are the various infections that has been diagnosed through this next generation sequencing. Astrovirus or even hepatitis E virus was detected in patient having a lung transplant. Okay, so neurobrucellosis, St. Louis, West Nile. So these are easily diagnosed through next generation sequencing. We have issues with the patients having septic arthritis who are coming here with sepsis. So whenever you are diagnosing the patient to be having a joint infection, so in that case you are sending a culture, and culture usually comes negative. So NGS is going to help you in diagnosis of that. Other infections like enteric or ocular or UTI, this is going to help you. So overall turnaround time is less than 24 hours, and if you go by the conventional method, turnaround time is around 72 hours or more. Also you can diagnose the carbapenem resistant genes as well. So in all the assays that we do, we usually detect either KPC, NDM, IMP, VIM or OXA48. But in the whole genome sequencing, you can always find new carbapenem resistant genes like OXA232, which we will never get in any other test. We can also do a next generation sequencing for detection of resistance in the tuberculosis. Discovery of novel pathogen, obviously, like we have discovered the SARS-CoV-2 and many other various hemorrhagic fevers or encephalitis patients have been diagnosed with this next generation sequencing. Regarding the public health, it will give you early warning and using it for the diagnostic purposes and dynamics of drug resistance. Now again, like I discussed, whether it is a contaminant, is a colonizer or a pathogen, that is difficult to differentiate. You have to judge clinically. Other hurdles like infrastructure, cost and build-up. So these are something we have to be aware of, and in future definitely we will come over it, and we mostly will be having this in our setup. So these are the smaller ones, the nanopore technology. Small machines are all there, so they are all doing sequencing, either DNA or the RNA molecules. So this guy is sitting in a village in Africa. So this particular small thing attached to his laptop, and he is using it for during the Ebola outbreak. As this is a picture I showed you, this particular gentleman is sitting in International Space Station, and he is using this that's attached to his tab, doing a next generation sequencing. So it is the method of last resort right now when your all diagnostic tests have been exhausted, but in 10 to 20 years definitely this will become the first choice. Regarding the limitations, and this I have discussed already, so this is the concluding slide. So what I discussed initially was the automated microscopy. This is exciting but definitely huge cost. Bacterial alert machine you are using for your blood cultures, so this is the gold standard, you have to always rely it right now. There are the film array techniques, multiplex PCR, so these are expensive, but definitely we are relying on this and we are really getting good results from it. We are diagnosing infections in a very short time, and you can direct your antibiotic therapy and overall therapy towards treating the patient with sepsis. Malditoff, we don't have it over here right now, but I have used it and it is definitely a very good option. And antibiotic imaging, it is under research, it's not freely available, but PET scan you can use if you are not able to find the source of infection. Next generation sequencing, it's coming up next, so be ready for that, and you can use it yourself in your own ICU. Thank you for your patient hearing. I took a long time for this. If there are any questions. Any questions?
Regarding the point of care test you are suggesting in the ICU or the bedside area, how are you going to maintain the quality? How to run the QC? You want to do it yourself?
No, QC will not be done by the clinicians. It has to be done by the microbiologist. Microbiologist will help you out. You can make a lab yourself, a small area maybe a small microscope. You can just have the Gramston and all. And if you have this small pocket next generation sequencing, you can do it over there. But QC will not be possible by us. That has to be done the microbiologist.
That is the trouble we are facing presently, to have a point of care test. Who is going to run the QC?
Yeah, that is the issue, because QC control will be difficult in the point of care test. So this point of care just for us. You will not generate any report. So that is the thing, that QC is not a big issue in that case, because this will just give an idea. Okay. You will not be signing any report of that.
Understood. Thank you.
Any questions from the audience?
Actually, sir, we are taking stool samples for testings. And actually, my concern is, if we are suspecting like pneumonia or blood infections, then how can we correlate with this test? Means it may be a colonizations or like that. Means.
So in the stool you are doing like a surveillance test, right? Is
okay,
it?
Means clinically is it helpful? Means
No.
to choose our antibiotics or like that.
No. If you talk about stool, so usually stool test is not recommended for expert carbar, because stool has got already so many microorganisms.
Yeah, right.
So, but if you are dealing with a transplant patient, you are planning for a transplant, and if you want to do surveillance testing, or maybe in the ICU you have got a protocol that you will take rectal swabs and you will do it routinely for all patients, and you want to know what all genes the patient is having inside the body. So that is, surveillance is something different. Okay. And if you are dealing with a sepsis patient with something like a respiratory infection or sinus infection, and you have a culture, you can put it in the expert carbar, you can know the genes and you can target your antibiotic therapy. But in stool it is different. You cannot simply extrapolate that directly.
Oh, okay, thank you.
Okay, if there are no more questions, we conclude this session. And may I request Dr. Pratik to felicitate Sayan.